Okay, hello everybody, and thank you for joining us today. Welcome to FAIR's free monthly webinar series. My name is Lynn Hewen. I'm FAIR's National Director of Education Initiatives, as well as your moderator for today's presentation on the diagnosis of food allergies and the role of oral food challenges. A little bit of housekeeping just before we get started. As with all of FAIR's webinars, this presentation will be recorded and posted on the FAIR website in about 7 to 10 days under our webinars section, which can be found under our education initiatives. Please note that for maintaining a quality recording, all attendees will be muted throughout the webinar. In addition to attempting to address the number of great questions we have received from our community in advance of today's webinar, many of which are incorporated into the presentation itself, if time allows, at the end of the presentation, we will have an opportunity to take questions. Because attendees will be muted, we ask that you please submit these questions via our questions feature, which is in your GoToWebinar panel. Please note that while this webinar will discuss medical issues pertaining to food allergy diagnosis and testing, the goal of today's session is not to provide specific medical recommendations for you or your child. It's not to interpret individual testing results or to provide a food allergy diagnosis. You should discuss questions of this nature with your healthcare professional, and suspected food allergies should always be evaluated, diagnosed, and treated by a qualified medical professional, such as a board-certified allergist. Today's webinar is also not intended to discuss updates in food allergy research or treatment methods. At this time, strict avoidance of food allergen is the only way to prevent an allergic reaction, and early recognition and management of allergic reactions to food are important measures to prevent serious health consequences. The goal of this webinar is to help provide some insight to ensure food allergies are appropriately diagnosed and understood so that these measures can be applied to your management and care plan. For those of you on Twitter, we encourage you to join us in conversation during the broadcast. You can follow us along with our webinar live tweets at our handle @FoodAllergy and the hashtag FairWebinar. All of our FAIR resources and education programs, including our free webinars, are made possible through community support. If you'd like to make a tax-deductible gift or become a FAIR member to advance our mission efforts, you can do so at foodallergy.org/donate. And so at this time, I'd like to go ahead and introduce our presenter. Dr. Shahzad Mustafa pursued his undergraduate studies at the Johns Hopkins University and attended medical school at SUNY Buffalo. He then completed his internal medicine training at the University of Colorado and stayed in Denver to complete his fellowship training in allergy and clinical immunology at the University of Colorado, National Jewish Health, and Children's Hospital of Denver. Dr. Mustafa sees patients of all ages out of the Rochester Regional Health System and is clinical assistant professor of medicine at the University of Rochester. He is involved with multiple national organizations, including the American Academy of Allergy, Asthma, and Immunology's Adverse Reactions to Foods Committee. Dr. Mustafa has lectured on food allergies at local, regional, and national conferences, including the 2015 FAIR National Food Allergy Conference in Long Beach, California. I'm very excited to have Dr. Mustafa here to present to you today, and at this time, I will turn the webinar over to him.
Thanks so much, Lynn, to you and to FAIR for having me host this webinar, and thanks for everyone out there joining about, I think, what's an important topic about food allergies, getting the diagnosis right, and what role oral food challenges play in that. So we're going to talk about the prevalence of food allergies, what kind of people think is out there, and what's actually real. We're going to define food allergies. This is kind of general outline for today. I think defining it is important because we want to all be speaking the same language, and food allergies is actually a pretty scientific term. So we'll kind of go through that. And then we'll focus on, obviously, the diagnostic process. How do you actually go through making the diagnosis of food allergy? And I hope to convey to you that the history, the patient history is by far and away the most important thing. And we only order testing in light of the history. Testing in the absence of the history is actually not particularly helpful, and I'll hope to show that to you. And then we'll kind of finish off and circle back around by discussing what role oral food challenges play in all of this, when to consider them, what effects they have, and whatnot. I'm going to try to get through this in a little bit of time and certainly leave time for questions. And as Lynn said, we've already kind of reviewed pre-submitted questions, a lot of good ones, which I'm going to try to weave into the talk, but if I don't, I'd certainly be happy to address that at the end. So I kind of wear two hats. Obviously, I do this for a living too, but my more important hat is I'm a father of three little people at home, and my best eater is my third guy, and my third littlest guy has a peanut and tree nut allergy. So I certainly take care of this all day at work, but then I go home and it kind of hits a little bit closer to home and affects that as well. So I think that's an important point. I've been in practice now for almost 7 years in AI, and my youngest was born 3 years ago. So having done this for 7 years, it still adds a different layer of complexity when he was born 3 years ago and diagnosed with food allergies 2 years ago. So it kind of gives me perspective for both the medical field, but also actually taking it home and how important this topic of the right diagnosis really is. So I like this quote from James Daly, who's an author. You cannot be distracted by the noise of misinformation. There is unfortunately a lot of misinformation out there in general, in the general media about medicine, allergies, but particularly food allergy. I think some of it stems from food allergy is a relatively new thing in the world of medicine. There wasn't much of it 30, 40 years ago, and there's a lot more of it now. And so it's relatively new, and with new stuff, we don't know as much as we'd like to know, and there's a lot of exciting research being done. But along the way, when we don't know stuff, that really leaves room for this misinformation. And I hope to dispel some of these myths today, because I think a lot of this is what feeds into sometimes the misdiagnosis of food allergies, which we certainly hope to avoid. So let's start with a definition. This is taken straight. There's a big practice parameters for food allergy. So this is taken straight from there. Food allergy is an adverse health effect arising from a specific immune response that occurs reproducibly. That's a very important word. It occurs reproducibly on exposure to a specific food. So there's a whole host of different types of reactions you can get from foods, which are not all food allergy. On the left side of this graph, on this table, we have immune-mediated reactions. So these are reactions to foods that occur when you eat something and your immune system responds to it. On the right side, there's a whole host of non-immune-mediated reactions. On the very far right, something called scromboid poisoning, which is eating spoiled fish. If you eat that, you get sick. That's a food allergy. You're not allergic to fish. So there's a whole lot of different types of reactions, and I'm going to focus on this on the next slide as well. And there's a lot of immune reactions. Today, with the diagnostics part, the diagnosis and food challenges, we're really going to be talking about the stuff to the very far left, which is IgE-mediated reactions. And IgE is kind of your allergic antibody. We all make antibodies, and folks with allergies tend to make more IgE. So we're going to specifically talk about this type of allergy, IgE-mediated food allergy. And to kind of take you through what this means to me, allergy is a very specific term. It means when you eat a food, your immune system, your specific antibodies, which is IgE, recognizes the food and mounts a response, and then you have subsequent symptoms. So that's what I mean by allergy. That's what's on the left side of this graph. On the right side of this is intolerance or sensitivity. That's not necessarily an allergy. And I think these words really are quite important, and I'm going to kind of take you through this and to try to show you the major differences, important differences between labeling someone with an allergy versus an intolerance or a sensitivity. And you can think of this in many ways. We can think of it with milk. Cow's milk allergy is a common allergy in children, and then lots of people know about lactose intolerance. So think about it that way. So if you have an allergy, it requires sensitization. And by that, I mean you cannot be allergic to something you've never been exposed to before. That's a very important point. The first exposure to a substance, whether it's a food or even an environmental allergen or medication, the first exposure to the food, your body makes these antibodies, this IgE. And then those antibodies just kind of roam around your blood. They don't do anything. And then the second exposure to the food or the culprit allergen, or the 100th, at some point after the first one, the antibodies become activated and you have an allergic reaction. So if today was the first time ever in your life you were given an antibiotic like amoxicillin and you had a rash today, I could tell you for sure that it wasn't the amoxicillin if you had never been exposed before. And the same goes for food. And intolerance, on the other hand, doesn't work through this antibody, so it can occur even on the first legitimate exposure, the first known exposure. So it doesn't require what we call sensitization. So allergy goes through IgE antibody. That's your allergy antibody, allergic antibody. We have very good diagnostic testing for IgE-mediated reactions, and we'll spend some time talking about that. Skin testing, blood work. When it comes to intolerances, we have very little, if any, diagnostic testing, and that's because we don't really know the mechanism of what causes an intolerance. So we don't really know how to kind of aim our targeted testing. So for lactose intolerance, although there is some testing, very rarely does someone do any testing for something like that. So that's another key difference. And allergy is reproducible. If you're exposed to something you're allergic to, food, you're going to have a reaction every single time. And intolerance can occur inconsistently. Sometimes you may tolerate it, sometimes you may not. That's very different. And allergy is generally dose independent. And what I mean by that is even a very small amount of a food allergen often can and will cause a reaction. And everyone, I think, on this webinar is sophisticated enough to know that. I mean, individuals, families with food allergies are reading labels because even a small amount can cause a significant and potentially life-threatening reaction. And intolerance is often dose dependent. Folks with lactose intolerance might be able to have a cube of cheese, for example, and they feel okay, but they cannot have an ice cream sundae. So that's a very key difference between allergy and intolerance. Allergy is often caused by an individual allergen, so one type of food. So you may be allergic to hazelnuts, but not other tree nuts. You may be allergic to one type of medication, but not others. And intolerance is often affects all types of things. So a good example in this in medications is ibuprofen or aspirin and anti-inflammatory agents. If you can't tolerate ibuprofen, Motrin, Bayer, Advil, aspirin, all of those, that's more likely an intolerance. If you can tolerate most of them but not one, that's likely an allergy. So this table, again, I think is very important. The allergy can, no matter what you do, you can't take medications and then consume something you're allergic to and expect to be okay. For example, my son has allergy to peanuts and tree nuts. I can't give him Benadryl and then give him PB&J. He's still going to have a reaction. Intolerances, often you can pre-treat. For example, folks with lactose intolerance can take a pill, a lactate pill, and then consume a little bit of dairy and they might feel fine. So that's a key important. If you're allergic to something, as an allergist, I can desensitize you. People are familiar with allergy shots for environmental allergies. So we can desensitize you if you have an allergy intolerance. You really cannot do that because, again, we don't know the mechanism. And this is very important. If someone has a true food allergy, they are at risk for anaphylaxis. They are at risk for death. They do need to have epinephrine prescribed to them. In school settings, they do need to have an emergency action plan. And intolerance has very little mortality and really no real risk of death. If you're lactose intolerant and get talked into having a glass of milk, you might not feel very good, but the likelihood of you having a significant reaction, death, it's not going to happen, whereas allergies certainly can. So these words certainly matter. I hope we're all speaking the same language going forward, with allergy being IgE-mediated and intolerance being a whole host of other mechanisms that we don't fully understand. So with that behind us, let's talk about true food allergy. True food allergy in the United States affects about 3 to 6% of children, which is about, average 2 kids per classroom, pretty prevalent, and about 3% of adults in the United States. That's interesting because if you called 1,000 people on the phone and asked them if you had a food allergy, anywhere from 20 to 35% will tell you they have a food allergy. But actually that number is really around 3 to 6% depending on your age. So self-reported, it's way over-reported by the population, by folks in the community. Even more interesting than that, I think, is it's actually overdiagnosed by physicians, not by folks, if you ask them, but actually their own doctors by as much as 80%. And I think that's obviously a huge problem. These labels have they have ramifications on people's quality of life, and we're going to talk about that. So why is this happening? Why is this overdiagnosis happening? So I'm going to prove this through a study. David Fleischer did a study in Denver at a big food allergy center. This was a kind of they looked at individuals' charts. These individuals came into their center being diagnosed with the food allergies on the left, eggs, the common food allergies, meats, fruit, what have you. They were avoiding these foods, and they were avoiding these foods based on blood work or skin test. They had already completed that. Those things were quote-unquote positive. They were avoiding these foods. They were avoiding 111 of these foods. These guys did oral food challenges. David Fleischer's group challenged all these individuals that were avoiding foods to the foods, And what you see is out of the 111 foods that they were avoiding, 103 of these foods were tolerated without any difficulty whatsoever. So what this study shows is, in this one case, if you are avoiding foods based simply on testing for food allergy, whether it be blood work or skin test, your risk of overdiagnosing food allergy is as high as 93%. And I'm going to try to explain to you why that testing can lead to such overdiagnosis. David, in the same study, took a history of foods. So now these are people who have told you that I eat a food, I have so-and-so symptoms. So they actually report that they've experienced a reaction to the foods. This occurred with 122 foods. Again, food challenges were done for all 122. And even when someone tells you that they ate a food and had a reaction, out of the 122 foods that they exposed to these individuals, 102 or 84% were tolerated without any difficulty whatsoever. So could that mean that it was misdiagnosed based on the history? It could. Could it mean that it was correctly diagnosed but someone has outgrown the food allergy over time? That's also possible. And that's an important point. People do outgrow any type of allergies, whether it's medication, but also food. So this study, I think, shows us the importance of getting the history right, but because even doctors with testing or talking to a patient are overdiagnosing this from anywhere from 84 to 93%, which is obviously a huge, huge number. Why does this matter? Well, I live with it every day at home. Folks with food allergies, it affects their quality of life. There's a whole bunch of studies comparing the quality of life of individuals with food allergy to other allergic conditions such as asthma or allergies, even to other conditions like diabetes. And the effect of food allergies on folks' quality of life is significant. In these surveys, 70% reported significant effects on social events, 60% reported significant effects on meal preparation, 40% of people said it overall increased their stress in life. And this is a big one for children. Aeon's 3 right now, my son. When he goes off to school, I think it'll be a little more stressful for us. That 34% report that it affects their school attendance. I mean, as a child, I think school attendance is one of the biggest things. Keeping kids healthy and in school is so much of what we do. And a third of folks reported it affected their attendance. And this last one is really kind of disconcerting to me. Is 10% of these people in these surveys said they chose to homeschool their children. Not because they thought homeschooling was superior or because their school district was inadequate. They chose to homeschool their children because they thought it was safer to keep their children at home than at school. So that is a significant impact on quality of life. This is another quality of life study, which is a little bit busy. Again, surveys of people with food allergies, about 90 families were surveyed, and check out what some of their results, and we'll kind of whip through this, because I think I'm preaching to the choir when I say if you're affected by food allergies, it certainly impacts your life. Meal preparation, anywhere from 60 to 70% said it significantly affected meal preparation. Going to restaurants, 80% of people said it affected what restaurants they go to, whether they go to restaurants. And on the right, you see 16% of people said they don't go to restaurants anymore because of their food allergy. I think that's a very big deal. Stress, free time, again, up to 40% of people says it increases overall stress. School is a big one for obviously children. Attendance, 34%, parties, 68%. So again, the majority of individuals with food allergy, children in school, are affected by this in their schools. Social activities such as sleepovers, attending camp. Check that out. A quarter of these people said they won't even send their child to a sleepover or to camp. These are important parts of development in a child's life. So food allergies are certainly having a grave impact on that. So this is obviously important. Getting this right is important. Again, like I said, I'm preaching to the choir. This is my own slide. This is my opinion kind of how you make this diagnosis. By far and away the most important thing that everyone would agree on is you need a detailed clinical history. That's where this starts. In the absence of a clinical history, which we'll talk about on the next slide, the testing is almost useless, not completely, but really, really not very helpful at all. Generally, especially in the hand of an allergist, after the history, the most important test is the skin test. And I'll tell you a little bit about that. That's simple testing. It's non-invasive. It's not difficult to do. It's routinely done on children. There's actually no age too young to perform skin testing in children. That's a common misnomer. I mean, we will sometimes skin test children for potentially milk allergy or soy allergy as young as 2, 3, 4 months of age. So the skin test is generally the next most important test. Immunoassay, by that I mean blood work, RAS testing, immunocap, your specific IgE levels. That's the third test. And sometimes you do all that and you still don't know. you don't know if someone's allergic. And what you follow that up with is an oral food challenge, which we'll kind of get through. So that's generally the overall framework of how you go through the process. So let's talk about history. 90% of allergic reactions to a food happen within 20 minutes of exposure to the food. 99% of allergic reactions to a food happen within 2 hours of exposure. These are generally very stereotypic. I eat food X, I get these symptoms. If I don't eat food X, I don't get these symptoms. What are the symptoms? 80 to 90% of reactions to food allergies have some dermatologic manifestations, some skin manifestations. People have hives, itching, flushing, very, very common, but also important to note that 10 to 20% of reactions, often the most severe reactions, do not have skin manifestations. So don't let the absence of a rash talk you out of food allergy, although rash is exceedingly common. With rashes, certainly you can get swelling of the lips, tongue, throat. That's part of that. That can occur. Respiratory symptoms are very, very common. Many of you know children with food allergies, adults with food allergies have other allergic conditions such as eczema, such as environmental allergies, such as asthma. So respiratory symptoms are quite common in manifestation of food allergy, difficulty breathing, wheezing, coughing, clearing your throat. That happens quite frequently. Gastrointestinal symptoms, GI symptoms are common. My personal opinion is kids tend to do more of this than adults. They get nausea, they vomit more often. I think it's self-defense mechanism. I just ate something that's bad for me. It's coming out of me, so they vomit it up. So GI symptoms are quite common. Diarrhea is on that list, although I think it's less common. It tends to be more crampy, abdominal pain, nausea, and vomiting. And then there's obviously a host of other things that can get more serious. Lightheadedness, passing out, and that way you're kind of getting towards anaphylactic shock almost. So these are common symptoms of food allergy. Just as importantly, I think it's important to know what are not common symptoms of food allergies. Isolated runny nose, isolated coughing, chronic asthma, chronic abdominal pain. These are rarely, if ever, manifestations of food allergy and typically don't even warrant an evaluation. I mentioned on the left, hives, acute hives that come and go might be food allergies. There's a lot of folks who have hives all the time, almost every day for months at a time. That's rarely, if ever, food allergy. And in fact, there's guidelines on how you diagnose for chronic hives, and it says right in there you shouldn't even consider foods in someone who's having chronic hives. Fatigue is not really a common symptom of food allergies. We talked about how these reactions occur inconsistently. I think the last one is very important. There's a huge overlap in children with eczema and food allergy. My son has a little bit of mild eczema. He obviously has food allergy. And the question comes up very, very frequently is, are food allergies causing my eczema? And I'm going to address that on the next slide. And in this, it says that mild to moderate eczema is generally not a manifestation of food allergy. I think that's very important. So the comment on eczema and food allergy, it's nothing is opinion. This is taken straight out of our practice parameters for the guidelines of diagnosis and management of food allergy in the United States. And right out of there, I just kind of cut and paste this right out of there. It says, in the context of moderate to severe eczema. So notice, in children with mild eczema, we're not even really taught to consider that food allergies are contributing. But in children, moderate to severe eczema, less than 5 years old, and my editorial would be this becomes really, really something to think about in the really young children, the kids who start getting eczema at 3 to 6 months of age, very early. So moderate to severe eczema in children, particularly young children, you can consider an evaluation for food allergy for some of the highly allergenic foods, that being milk, egg, peanut, wheat, and soy, if one of the following conditions is met, and these are key. The kid has eczema despite optimal therapy. Many, many children who have eczema are not being optimally treated. So if you have eczema despite doing all the right things, and or you have a history of eating a food and having an issue with your eczema, if those things are happening in a young child with moderate to severe eczema, then is when you think about food allergy. In children with mild eczema, who aren't kind of taking good care of their skin, who aren't on topical steroids, who have a lot of itching, who are dry skin, you really shouldn't think about food allergy until you maximize their therapy. And the other, I think, important point is when you worry about food allergens contributing to someone's eczema, the most common food by far is cow's milk in that setting. the top four by far, I think, would be milk, egg, wheat, and soy. So if you're considering that food allergies are affecting someone's severe eczema at a young age, despite doing all the right things, you might want to consider evaluation for milk, egg, wheat, and soy. I wouldn't go too far beyond that. And this is straight out of the guidelines. So I think that's an important point that comes up quite frequently. So what are the common food allergens? In children, the list is on the left, and in adults, the list is on the right. In children, it's milk, eggs, peanuts, nuts, wheat, soy, seafood, and sesame. I have an asterisk by because it's kind of the new kid on the block. Sesame allergy has been increasing. I barely saw it when I was training just 7 years ago, and now it's kind of tracking very closely to peanut and nut allergy. So I have an asterisk there that these numbers are a little bit old. They're pretty similar now. I think milk would be around 3%. Sesame is probably closer to 1%, but the rest of the numbers are generally kind of same ballpark. In adults, the list gets even shorter. It comes down to peanuts, nuts, and seafood and sesame. So we eat there's over 10,000 foods in the diet that folks eat. Roughly 170 foods in our diet have been attributed to having caused food allergy, not any more than that. So out of the 10,000 foods, about 170 have been kind of attributed to causing food allergies, and from that 170, this list is what accounts for about 95% of food allergies. So when you come to see me, it's a lot easier for you to convince me that you're allergic to milk or peanuts or shellfish than it is if you're allergic to Brussels sprouts or carrots or what have you. So this list is where we start. Can you be allergic to other foods? Of course. But this list covers the vast majority of food allergies. So I think it's very important when you're talking to someone about what their food allergies are, talking about what the foods are and if they are on this list or not. So now you've taken a history. You've talked about what the foods are. You think that someone may have a food allergy. How should you do the diagnosis? You start generally with skin testing and blood work, which is called RAS or immunocap. Here's the key part there. What you're testing for is the presence of IgE, that antibody we talked about. It doesn't tell you anything more. So skin testing is kind of like your pregnancy test. It tells you qualitatively whether someone makes IgE or not. And then blood work is your quantitative test. It quantifies it in a specific number. It's kind of like if you think you're pregnant with a pregnancy test, you might go to your OB and they draw some blood work for your beta-HCG. So it's a qualitative, do you have antibody, and then potentially blood work of how many antibody you have. That's what this test is telling you. What this test is not telling you is, do those antibodies, are they active? Do they actually do anything? Do they cause reactions? And that's a key point. To have a food allergy, you have to have two things. You not only need to have the antibody to the food in your system, but the antibody needs to become activated and cause reactions, clinical reactivity. The key is, if you skin tested 100 people just off the streets for food allergies, anywhere from 40 to 60% of those people would have quote-unquote positive skin testing or blood work. But we certainly know that 40 to 60% of the population does not have food allergies. It's about 3%. So that's where it goes back to that study that I showed you from Denver, that if you are basing your diagnosis of food allergy just on testing, you are going to significantly overdiagnose food allergy, because all you're doing is asking if someone has an antibody or not. If the antibody is not doing anything, that doesn't mean they have a food allergy. That doesn't mean they're going to develop a food allergy. It doesn't mean they're at risk for food allergy. It's a normal response that lots of folks in the community have. So you need to have the antibody and clinical reactivity, the symptoms that we just talked about. What is skin testing? We put a drop of the antigen on your skin. If you're not allergic, nothing happens. If you're allergic, you get kind of like a little mosquito bite, a wheal and flare response. You see a little bump, you see redness. And it's a very, very helpful test, because a negative skin test makes food allergy exceedingly unlikely. Not impossible, but very unlikely. If you don't have positive skin test to a food, the likelihood that you have a food allergy is way less than 5%. The key for the skin test and the blood work is, as the reaction gets bigger, as the size of the skin test gets bigger, or as the level of the blood work gets higher, it becomes more and more meaningful. So a skin test, if the bump of the skin test for egg is 3 millimeters, the likelihood of you having an allergy is, say, roughly 50%. However, if the mosquito bite, the bump, the wheal, if the wheal is more than 8 millimeters, the likelihood of you having the allergy is more than 95%. So I think it's very important not to say whether you had a positive or negative skin test or positive or negative blood work. I think the size of the skin test reaction or the level of the blood work is very important. We'll talk about blood work on the next slide, but a level of 0.8 is very, very different than a level of 80, for say. So once you've taken the history, you've done the skin test, then you potentially do some blood work. And this is what I'm talking about the blood work. The levels of blood work are very different, and they're studied for some foods. Let's, for example, take peanut, which is kind of in the middle of the chart. If your level of peanut, your blood work for peanut, your specific IgE level, your immunocap level, is 14 or above, I can tell you that you have a 95% likelihood of having a true peanut allergy. If your level is 20, 70, 80, you likely are truly allergic to peanuts. For peanut, for example, if your level is 1 or 2 or 3 or 0.8 or 1.9, the likelihood of having a peanut allergy is really no greater than 50%, which is pretty much like flipping a coin. So every food, the level is very important, and these foods that I have listed here are well studied, and we know what levels are meaningful and what are not. So to give you an extreme example, if you have a 1-year-old kid who has eaten peanuts on 2 occasions and both times had hives right away, and you do blood work and his level is 0.1, given his history, I think that child is allergic to peanuts. But if you have someone who eats peanut butter and jelly all the time, and someone mistakenly checked the blood work on him, and his blood work for peanut is 6, and he eats it all the time without any problems, he is absolutely not allergic to peanuts, even though his level of peanut-specific IgE is higher than that child. So the blood work can only be interpreted in light of the history, and that's just a specific example for peanut. These numbers are different for different foods and different ages, but for milk, for ages over 2, it's 15. So things below 15, less helpful. Things above 15, quite helpful. Egg, it's 7. We don't have these numbers for many foods, and even wheat and soy, which are fairly common food allergies, especially in the young age, our numbers are not great. Levels of like 5 and 10 are not particularly helpful, but when you get over 30, I think they become much more significant. So those are kind of the tests we use after the history. We do skin testing, we do blood work. There's a whole host of unproven diagnostic tests for food allergies that are being offered through various providers, alternative medicine. You can even get them out on the street. You can pay cash for them. You should never do intradermal skin testing. This is kind of a skin testing with more than just a prick that I described by putting the antigen on the skin. This is actually injecting some antigen beneath the skin. You can sometimes do that for environmental allergies. You can certainly sometimes do it for medications. You never do it for food because there is a much higher risk of anaphylaxis. Atopy patch testing comes up. That's not skin testing. That's more of delayed testing that you leave on your skin for 48, 72 hours. That's not validated. This testing comes up all the time. My colleague was just talking about a patient he saw who had IgG testing for food. That is not encouraged. It is not validated. IgG is an antibody that we make to everything that we are exposed to. So if you check IgG for foods, the vast majority of us will have detectable IgG for food. That has nothing to do with allergy. Basophil activation testing is interesting. It's being studied right now to help with the diagnosis, but it is not validated. There was a paper published from Mount Sinai last year about potentially using this testing to predict the severity of reaction, which would certainly be nice. That is still in testing. It is still not commercially available. No one's doing that. As of today, in food allergy, unfortunately, although I would love to, I cannot predict the severity of your next reaction. The testing does not predict that. If your blood work for peanut is 100, that does not mean you have a risk of higher or more severe reaction than if your blood work for peanut is 1. So the blood work helps follow the allergy over time, but we have, as of today, no way to predict the severity of the reaction, but this basophil activation testing is something we're studying. There's a host of other tests there that are not encouraged or validated by food allergy guidelines. And it also says at the bottom, don't order huge panels of testing because you don't know what to make of the results. Like I said before, the testing is really only interpreted in light of the history, what the patient tells you. So we talked about the history. We talked about 80 to 90% of folks having skin manifestations, maybe respiratory, maybe gastrointestinal. We talked about skin testing and how as the reaction becomes more and more reactive, it becomes more and more meaningful. We talked about blood work. Sometimes we still don't know. And that's when you have to do an oral food challenge. That's what we're going to kind of talk about here and kind of circle back around. So when do you do an oral food challenge? An oral food challenge is done for two reasons. One, it's performed to confirm or refute whether someone has a food allergy or not, to make the diagnosis or to reject the diagnosis. Because I told you, many folks are overdiagnosed with food allergies, so we often do these to prove to them that they're not allergic, that in fact they can consume a food that they are already avoiding. The other very important reason to do an oral food challenge is to confirm if someone has outgrown a food allergy. People outgrow food allergies. The vast majority of children outgrow allergies to wheat and soy. 80 to 90% outgrow allergies to milk and eggs. Even 20% outgrow their peanut allergy. So the only way you can tell someone that they've outgrown their food allergy is to perform a food challenge. There's always a question about when to perform a food challenge in someone who has a known history of food allergy. Every food is different. Every history is different. Performing a food challenge in a 2-year-old is different than performing a food challenge in a 12-year-old versus a 22-year-old. So there's no black and white numbers that say, in this, when the blood work shows this, do a food challenge. Every food has different cutoffs. The general consensus is you consider that someone has outgrown their food allergy if they've had no reactions in a year and their skin testing has, it doesn't have to be negative, but it has to be not gigantic. The reaction cannot be huge. And their blood work has dropped to levels that are sufficiently low. And those numbers are different for many foods. For many foods, it's around 2. So in someone with milk allergy, if they're 7 years old, they've been avoiding milk all their life, they haven't had a reaction in 3 years, their skin test is a little bit of redness, but not much, and their blood work is 2.6 or 1.6, you might consider doing a food challenge. So that's the general consensus, but a specific time of when to do a food challenge is very hard to kind of say black and white. I think it's very important to note that skin testing often remains positive despite someone having outgrown allergy. It kind of lags. So my analogy here is the blood work is a jet ski. It's very dynamic. It changes year to year. Skin testing more is like a tugboat. It's much less dynamic. It changes very slowly. So if someone outgrows a food allergy, they tend to outgrow it before the skin test turns negative. So important points about a food challenge. What is it? A patient must be in good health with allergic conditions optimally controlled. So you don't want to expose someone to a food to make a diagnosis of food allergy if they are in the middle of viral flu illness. So someone should obviously be afebrile. A lot of these folks have asthma. Their asthma should be well controlled, because if you're doing a food challenge in someone with poorly controlled asthma and they tend to have a reaction, you certainly don't want to set off their asthma. Preparing for food challenges, families should discuss with their doctors about potentially stopping medications that may interfere with the challenge. We generally have folks stop antihistamines before the challenge because you don't want to block any early symptoms of itching or rash. So that's something to consider. Patients should generally plan on half a day. So the general protocol is you come in to a facility. Some facilities have you bring a food. Some facilities provide the food. You're giving increasing doses of the food, typically 6 doses on the bottom every 15 to 30 minutes in increasing amounts. And so that generally takes about half a day. Certainly this can be longer in case you have a reaction and you require treatment. We're going to talk about that. The challenge, although you're doing it in hopes of someone passing, needs to be conducted in a facility capable of handling significant allergic reactions with epinephrine. Because anytime you're doing a food challenge, there is a risk of reaction, there is a risk of anaphylaxis. If there was no risk for reaction, no risk for anaphylaxis, there'd be no reason to do the food challenge. You could just go home and eat the food. And like I said, the food is given in increasing doses at fixed intervals until you either tolerate a full serving, or obviously if a patient has a reaction, you stop and treat the reaction. Because of the way the food challenge is done, it starts with very low dose, exposure to the lips, then a very small amount, and then increasing amounts. They're generally well tolerated. This is a study from Mount Sinai, which is a huge food allergy center, that looked at all of the food challenges they did in generally a pediatric population a couple of years ago. And in those 2 years, they did 700 food challenges, and 132, about 20% of these, 1 out of 5, had a reaction. So 80% of these people passed the challenge. They were able to eat the food. 20% of people confirmed that they had a food allergy. Out of the 132 folks who had symptoms with the food challenge who were truly allergic, 75 of those, about half of them, had only skin symptoms, and the majority of these were treated with just Benadryl because of the way, or just an antihistamine, because of the way the challenge is done. Less than 2% required epinephrine. Only one patient out of 701 required more than one dose of epinephrine, and this same patient was sent to the emergency department for further treatment. This is generally the safety profile of food challenges. Our practice, I'm very proud, our practice has 5 allergists, 3 offices, and we do roughly 15 to 20 food challenges a week. We've been doing this for now about several years. I have treated in that time period, similar to this data, only one individual. It was a teenager with tree nut allergy with multiple doses of epinephrine, and I also had her observed in the emergency department. So they are generally very, very safe if done at the hands of someone who knows what they're doing with food allergy and food challenges. So they're quite safe, so certainly part of the evaluation. I think this slide is very, very important about people's perceptions of food allergy and or the importance of food challenges. This is a study that looks at quality of life in adults and adolescents. There was a similar graph for children, but I didn't put it on the slide. It looks at someone's quality of life following a food challenge. So it makes sense if you look at this graph. If someone passes a food challenge, it makes sense on the left that the brown bar shows you that their quality of life is improved, right? That makes sense. You come in, you're avoiding a food, you do a food challenge, you're able to consume the food. So your quality of life makes sense that you can eat a food, broadens your diet, you have to be less strict about reading labels, maybe you don't need to carry epinephrine anymore. That's the brown bar on the left. So out of these folks who passed the food challenge, anywhere from 60 to 70% said their quality of life improved. I think that's expected, but good to see. What's interesting is this next bar. In individuals who have a food challenge and quote-unquote fail the food challenge, who have symptoms during the food challenge, they have a reaction. They do truly have a food allergy. Even in those individuals, anywhere from 25 to 45% of these individuals said their quality of life still improved after the food challenge. I think that's very important. Why does that happen? If you fail a food challenge, why does your quality of life improve? I think it shows people that, A, they were avoiding a food for a good reason, that uncertainty is taken away. It's very empowering to know that, yes, I've been told I'm allergic to, seafood, and I love eating seafood, and I'm avoiding seafood now, but at least I'm avoiding it for a good reason. When I consumed it, I had this reaction. I think that's very important to note here. The other reason I think many people have an improved quality of life following a quote-unquote failed food challenge is some of these do require treatment with epinephrine. And we're all quite nervous to use epinephrine if needed in the community with my child, what have you. And if you use epinephrine with a food challenge, invariably these families tell you that they feel empowered that they saw epinephrine used, they saw how easy it was, they saw how effective it was, and they saw how safe it was. And most people will tell you if they use epinephrine once, if they have to, generally speaking, they feel more comfortable using it in the future. So I think those are two important parts of why even if you fail a food challenge, quality of life often improves. So in my practice, when we do food challenges, I tell individuals, if you pass, that's great, but even if you have a reaction today, I don't think that's a failure. I don't think that means we shouldn't have done this. This is absolutely the right thing to do. Because if you do have a reaction, then at least we know we're avoiding the food for a good reason. Whereas right now, we have some uncertainty of whether you're avoiding, why you're avoiding the food. So food challenges are not only safe, but they're effective in proving whether someone has a food allergy, outgrown a food allergy, and I think they play a significant role in someone's quality of life. So that's kind of taking you through the diagnosis of food allergy. It's certainly overdiagnosed, not only by folks in the community, but also by physicians. That's on us. That's on the medical community. We need to get better at knowing when to order these tests and how to interpret these tests. And you really need to be in the hands of someone who knows the testing, not just blood work, but hopefully skin testing too. By far and away, the most important part of making an accurate diagnosis is the history. Certain histories are very consistent with food allergies. I eat shrimp, I get hives. Things like, chronic abdominal discomfort, chronic diarrhea, these things are generally not a history consistent with food allergy. And then based on the history, you order validated testing, skin testing and blood work, and you have to interpret that in light of the history. And if you don't know still, if the diagnosis still isn't clear, you think someone has a food allergy, they may have outgrown it, I think food challenges are certainly essential if you're going to take care of folks with food challenges. if you're going to take care of individuals with food allergies, you really do probably need to be doing food challenges in your office. They are generally safe, they are well tolerated, and they certainly improve quality of life. That's kind of what I have for you. I think I'm going to turn it back over to Lynn to help me out if there's some questions that I need to address, and we'll go from there.
Great. Thank you, Dr. Mustafa. And we do have some questions. There are some good ones, and I know that there may be some more that come through. Just a cursory point that if you are asking questions, because we do receive kind of high volume, try to make sure that they are targeted towards a general audience. It's very hard to get through them when there's a lot of commentary that kind of comes along with them, and try to make them, we'll try to address some of your individual questions, but do try to make sure that they are able to be targeted towards a large group. And as I had mentioned previously, we are not trying to dispense any sort of medical advice, or speak to your individual allergy care plan, but we are going to try to offer some good insights. The first question that we have is for somebody that is interested in doing an oral food challenge, and her concern is they are trying to confirm outgrowing egg and baked milk, but there's a high level of anxiety. So mom is a little bit worried that he is going to report symptoms like itchiness or tingling with the upcoming food challenges that he's doing. She wanted to inquire about, to talk a little bit about, blind testing or trying, what are some methods that she can sort of employ or some strategies in terms of trying to get some of the noise of anxiety out of the picture.
Sure. Lynn, is it okay if I go back in the slides here?
Yeah, absolutely.
So I think that's a very, very good point that I didn't address on this slide is folks with food allergies certainly have an appropriate amount of anxiety and sometimes have a lot of anxiety. And food challenges, there are sometimes a decreased, if you look in these charts, decreased quality of life. That's the blue bars. So preparing for a food challenge is done for the patient and or the family. It's not done for a physician. So it has to be done when the patient and or the family are ready to do it. And anxiety is a big part of that. So certainly preparing for that ahead of time. The gold standard, the perfect food challenge is something we call a double-blinded food challenge where the patient doesn't know if they're getting truly the food versus kind of a placebo or, not the food protein, and maybe even the physician doesn't know. Practically, that's not what the vast majority of physicians in the U.S. are doing. We're doing open food challenges where you want to eat the food, so you know what you're getting. So, anxiety, I think, is a very appropriate and expected part of this. If it's going to preclude you from doing a food challenge that you want to do, I think you need to work through it before you get there. I've had many people show up, try to do a food challenge, and it's just too nervous. Telling a child who's avoided a food for years potentially that, here you go, eat this food, and they're not hardwired to do that, and it takes a couple of tries. It takes some working with. You need to have patience and compassion, both friend, family, parent, office staff, physician, everyone involved. So it is something you need to work through. But in some cases, it is beneficial to do a blinded food challenge where the individual doesn't know whether they're actually getting food or a blind kind of a placebo dose. And there is a role for that, and I think that's appropriate because anxiety is not a fault in this situation. It's a part of this condition. And the anxiety with having a reaction, particularly if someone's had significant reactions previously of having that in the office, is very real and appropriate, I would say.
All right, thank you. A couple people have asked a little bit about if you pass an oral food challenge and it's sort of determined that you've outgrown your allergy and you haven't reacted, are there recommendations in terms of still carrying epinephrine and what is the likelihood of future reaction, after sort of passing an oral food challenge? It seems to be a topic of concern for a few of our listeners today. That's
a great question. So once you pass a food challenge, it's what we call the gold standard, that it is as definitive as anything we've got that you are no longer allergic to that food. The only food that has been proven, that has been shown in the medical literature and the research to where someone passes a food challenge and can develop the allergy in the future is actually peanut. In someone who passes a peanut challenge, again, it's study, I think this was done out of Hopkins. The author was, again, actually David Fleischer, shows that up to 8 to 14% of those individuals can redevelop their peanut allergy in the future. So if we can decrease that risk if you consume peanut in your diet on a relatively regular basis. So in individuals who I do peanut challenges for, if they pass it, I encourage them to keep it in their diet because that decreases the risk of recurrence, which is 8 to 14%. As far to my knowledge, there's no other reports in the literature of people passing food challenges and then experiencing recurrence of those allergies in the future. And that would apply to milk, eggs, wheat, soy, and a whole host of other foods. So I would reassure you with food challenges, if you're allergic to food, you pass a food challenge, your likelihood of recurrence in the future is, never say never, but exceedingly, exceedingly low, with the exception of peanut. And with peanut, if you keep it in your diet, you can make that risk of recurrence much lower than what it can be, which is as high as 8 to 14%. As far as carrying epinephrine, there's no black or white recommendations on whether you should do that after you pass a food challenge. I think that's a discussion you have with the patient, with the family. If they feel more comfortable carrying epinephrine, they can afford it because, as we all know, these are pricey, and they would like to carry it and it improves their quality of life. I think that's fair. I think for most foods, if you pass a food challenge, you probably don't need to. It's not necessary to carry epinephrine afterwards. The exception, again, maybe being peanut. And this certainly comes up with children in school and emergency action plans. But if you pass, a food challenge for milk or eggs and you're in grade school, I don't think it's necessary to have epinephrine available at school or an emergency action plan. I think it is pretty reassuring that you should do well going forward with little to no risk of recurrence.
Great. On a related note, and sort of on the other side of the coin, a few people have asked about if you fail an oral food challenge, is there any sort of guidance in terms of when you can or should attempt one again?
Yep. Good question. There's no specifics here. I think the reaction is important. I think when the reaction happened, if it's in the first dose with mucosal exposure, if it's much later with a larger dose, at minimum, I think you should wait a year. And then beyond that, I think it's a little bit, you got to individualize it to the patient. Different foods are different. We know that most children who outgrow peanut allergy outgrow it between 5 and 10 years of age, around an average of about 8 years. We know many children with milk and egg outgrow allergy between 5 and 10 years, sometimes into adolescence. Wheat and soy is even sooner. So if you're a 2-year-old who failed a peanut challenge, it might be worth revisiting in a year or two. If you're a 20-year-old who fails it, you may not want to revisit in a year or two because your chance of outgrowing at that point is much lower. So definitely wait a year. Definitely should revisit the diagnosis. The specific timing beyond a year is hard to say. I do think it's important to always have updated data, and that includes blood work and likely skin testing also before you do a food challenge. You want to have updated data. Old data is not particularly helpful. One other point I want to make about diagnosis and food challenges, and this question had been submitted earlier, about component resolved testing. It is not quite ready for prime time. It is not widely commercially available right now, although you can order it. This is testing. When we check blood work right now, we check for the major protein in the food allergen, and component resolved testing is actually a part or a portion of the protein. So it can potentially help with our diagnosis, and the goal is to be making better diagnoses without requiring as many food challenges. There's a lot of research going on. We are starting to use this more on a broad spectrum, widespread level, but it's not quite commercially available throughout the U.S. just yet. But that is something certainly that there's a lot of work being done on to improve our diagnosis and hopefully cut down on the need for food challenges.
I'm glad you brought that up because somebody was inquiring about the difference between the component testing and the basophil activation testing.
Yeah.
Getting back to some of the other testing methods that are out there. Somebody was inquiring about, and I think this goes back to sort of our unproven methods slide, the accuracy of salivary IgA testing for food allergies. Apparently, somebody's husband was diagnosed with an allergy using that test.
So salivary IgA testing is not a validated test for IgE-mediated food allergy. IgA is our kind of mucosal antibody. IgA is our defense system to fight infections anywhere where we have mucosa, so our mouth, our GI tract, throughout our GI tract. There has never been a study, to my knowledge, that shows that it has any utility in diagnosing if you have food allergy or not. And I never want to be carte blanche. There's a lot we don't know, but as of today, what we do know, it doesn't have any utility, and we certainly do not recommend it. And that can be on this list with this host of other stuff that's being done. So simply taken, I don't think that's particularly helpful. I would potentially revisit that diagnosis depending on what other circumstances are going on.
Great, thank you. A few questions have come through related to breastfed babies. Just kind of asking about the possibility of food allergies showing up in entirely breastfed babies, and also, you know, some best practice guidelines in terms of food avoidance trials for mothers. I know that was one of our questions that had come in a little bit earlier, and I'm wondering if you might be able to talk about that a little bit.
Great question. So I'll go back even before breastfeeding. So in pregnancy, as of today, there is no literature to support that pregnant mothers should be avoiding any particular foods. Some studies show that avoiding highly allergenic foods in pregnancy may decrease the risk of allergy, but other studies show that avoiding highly allergenic foods during pregnancy may increase the risk of allergy. So I'm a man, I don't have a right to say this, but I'm pretty sure pregnancy is tough enough as it is. So unnecessarily eliminating foods in hopes of decreasing your child's risk of food allergy is not what we can recommend. So as of today, the guidelines say in pregnancy you can consume whatever food you want. Don't really have as much control over your child's food allergy as we wish. Breastfeeding, very few food allergens, very uncommonly do food allergens get through the breast milk of the mother and her dietary consumption affecting the child. With that being said, it certainly has been reported, and it certainly does happen. By the time a mom eats something, it's broken down through her gut, and then protein gets into the breast milk and into the baby. Most of it is quite broken down, and it's very unlikely to cause a reaction in the baby, although it is possible. But you would kind of see the same thing of where the baby is having reproducible and reactions consistent with allergy. It's not generally vague. I don't think an upset baby, a fussy baby, colicky baby would be where I would start removing things from the mother's diet. I think that's very important. We also see in exclusively breastfed children who are completely healthy and thriving otherwise, sometimes blood streak stool. And that's something we call protein proctocolitis, and that is often caused by the mother's consumption of milk and soy, but it is actually not a true food allergy because it's not IgE mediated. And recommendations on what the mom should do there kind of depends on a whole host of other things. So the general answer is a mother's diet generally does not have a huge role on childhood manifestations of food allergy, although it is possible. But again, the key is the history. You can certainly consider elimination diets in the mother to see if the child gets better. And if you were going to consider a food, I think by far and away, again, the most common is cow's milk. Just like I said for eczema, cow's milk would be the most common. Soy is probably pretty common too. And eliminating that in mom really has to be cold turkey. It's not just no more cream and coffee. It could be as drastic as no more cow's milk protein at all, even butter and things like that. So it's not easy to do, but in some cases, not many, I think it does have a role, and I think you need to be in the hands of a good allergist to kind of tease that out.
Great, thank you. Very helpful. I think we have time for one more question. This is from an adult with food allergies who has experienced what sounds like some adult onset, but is confused by testing results. Blood and skin tests have shown negative for soy, but he has experienced a trip to the ER after drinking a soy protein drink and subsequent follow-up testing. Yet today, both blood and skin tests are negative. He's confused and has received varying feedback from different allergists and is trying to make sense of his medical history and his, previous symptoms compared to the testing.
Sure. So I think, again, the key is the history. There's lots of reasons people experience hives. There's lots of reasons people experience lightheadedness or passing out or rashes. And the key is the history. So based on that, you do a diagnosis. In an adult, soy allergy in an adult is very uncommon. Soy allergy in a child is one of the common food allergies, but as you get older, the risk of soy allergy goes way down. And, so this is a little bit glib, but, we talk about in our practice, everything in this world happens after you eat. We're always eating. So, when you experience symptoms, it's often our natural instinct to attribute it back to the last thing we ate, and it's not always food. So, again, not speaking to specific medical advice, but in an adult worried about soy allergy with negative skin tests, which I told you has a fantastic negative predictive value, and undetectable IgE levels, the likelihood of being truly allergic to soy is very, very little, close to none. So you really have to look for other causes of what may have caused that, and that happens kind of all the time. We see this all the time with folks with hives and passing out, and there's a whole list of other medical conditions that an allergist or your provider should be thinking about beyond food allergies that can be evaluated with blood work and other testing.
Great. I think that brings us to just a little bit after 2 o'clock, and we have received some additional questions, and if you haven't had your question answered to us, obviously Dr. Mustafa has provided his contact information very graciously here, so I'm sorry if you're flooded with emails after this, but you can also send emails to me. There are some questions that are related that I've seen that have come through to understanding anaphylaxis a little bit better, and we do have a very robust webinar archive that addresses some of these specific issues as well, school-related issues and things like that too. So please make sure that you, under our educational initiatives section of the FAIR website, foodallergy.org, please feel free to access any of our webinars. And you'll see with this webinar, as with all of our past webinars, there are slides available for you to access. There are recordings of our webinars to access. So please take advantage of our resources that we keep archived. If there are additional questions that you have that you'd like to direct to me as well, you can email me at lheun@foodallergy.org. I'd like to, at this point, just kind of promote our next month's webinar, which is about participating in a research study. It's going to be presented by Dr. Todd Green, who is with the Children's Hospital with UPMC in Pittsburgh. And Dr. Green is going to present on some of the considerations that you might look at when you're thinking about participating in a research study for food allergy treatment or understanding food allergy a little bit better. So we will be having priority registration open for FAIR members on Friday, February 26th, and general registration will open on March 25th, and Monday, March 28th is when the member-only registration and the general registration will open. I'd really like to thank Dr. Mustafa for joining us today, for his incredibly valuable insights. Again, in case you missed any portion of the presentation, this presentation will be recorded and available as a resource on FAIR's website in the coming days. It usually takes us about 7 to 10 days to get everything up. After this webinar, too, you're also going to get a little notification for a survey, and it'll show up in your post-webinar follow-up email from FAIR that you'll receive tomorrow. It just includes a short survey link that will be included for you to share feedback on today's presentation and to provide comments on webinar topics you'd like to see in the future. So if you could, please take a minute to complete this. It'll help us to continue delivering meaningful information to you and helping design our content for the future. That will conclude today's webinar. So thank you all once again for joining us, and we hope to see you again next month.